Hi everyone, welcome to the section of cardiology. This is Dr. Jaitly. In this video vignette, I'll be talking to you very briefly about the basics of what is a nuclear stress test. Sometimes it is suggested to someone, many times you just want to grasp it right before your exams or what have you. What is a nuclear stress test? So I'll give you a basic spiel on this, if you will. Well, we know what a stress test is, right? A stress test is basically making the person walk on a treadmill while monitoring the EKGs, the blood pressure, the leads are attached to the person, and you're looking at the heart rate. And then you're looking at the EKGs to see if there are any ST changes or anything that is suggestive of an abnormal response, and determine whether or not this patient has any problems with the coronaries. Now, these are the two coronaries I've shown here in a small little diagrammatic, schematic figure here. Two sets of coronaries, right coronary running like this, which mostly supplies the right side of the heart and then curves to supply the back side of the heart. And the LAD, or the left main, dividing into LAD, which is left anterior descending artery going into the front of the heart, and the circ, which is left circumflex as it's called. It's curves around behind the heart and supplies the rest of the left side of the heart as well as the back. Okay, so the entire perfusion, we call it, myocardial perfusion, is nicely balanced between these two arteries supplying the entire heart. How does the perfusion appear in the setting of a nuclear examination? Now, we also call it a myocardial perfusion imaging test. A nuclear stress test is also called a myocardial perfusion imaging, or MPI. Now, in short axis, for instance, the ventricle will look like a hollow of a glass, like you're looking at a donut. So obviously this becomes the anterior, this wall. This is your lateral wall. This is your posterior wall or inferior wall, and this is your septal wall. Now, in a vertical axis, this becomes your anterior wall. This is your apical, and this is your inferior wall. And then you have a septal wall here in the horizontal view, and an apical wall, and then a lateral wall. Okay, so let's go over again: anterior, lateral, posterior, and septal. Here we have anterior, lateral, and inferior, and here we have septal, apical, and lateral. So all walls can be seen, because remember, a heart is like a three-dimensional structure, like any other structure, so obviously it has to be seen across. So now when you combine a stress test where the person is walking, like I'm showing you on the left side of the panel, along with the stress imaging perfusion test that's being performed here at the same time, that gives you a better idea as to what's going on with the heart. Now, anterior is represented by, as I said, the LAD, or the left main, if you will. Lateral is represented by circumflex, and the posterior is represented by RCA, which is the right coronary artery. So see, now even when the stress test, say, is normal, we'll have a normal perfusion looking like this. That means, look at this. The perfusion imaging will look like this, because the radioisotope, which is normally technetium-99, that's injected during the stress time, and if there is no perfusion defect, we call it a normal perfusion. That means the entire donut is complete, quote unquote. Here, look at this. The entire perfusion is intact. Here again, the perfusion is intact. That means the isotopes will be picked up by the scanner wherever the isotopes or the gamma particles are being recorded. Now, where there is no perfusion, you will have filling defects. Now, look at this. We have an RCA, or a left circ lesion. That means the right coronary and the circ. If there are two vessel disease, what will happen is the lateral wall will be affected, the inferior wall will be affected, and you can see the lateral wall not lighting up again. So in all three views, when it's compared, you could tell that RCA and left circ are involved because of filling defects in those walls or regions. So that is the regional abnormality, and obviously during the stress, these will be the filling defects. Now, these filling defects during rest will fill up like this, and they will look like this. However, during this, even in resting, if they look like this, then we have a problem. That is a fixed defect. So a reversible defect, if it reverses in rest, it looks like this. If it reverses in rest, looks like this. If the whole thing reverses in rest, looks like this. Then we know it is a reversible defect secondary to ischemia, because during the time the stress occurred, the filling defects were present. During the time when the rest images were done, after the injection, all fillings were complete. That means there were no filling defects. Now, similarly here, I've shown another territory, which is the left anterior descending artery. Now, where is the left anterior descending artery? Right here. This is your left anterior descending. So it's supplying the major chunk of your left ventricle and the front of the heart, front wall of the heart. So look at this. So here it's applying the septal wall there, which is very important because that's where the entire bundle branches are going. This is your anterior wall, you can see that. And here's your septal and apical, because LAD runs almost to the apex. So it'll involve the apical as well. So these are the schematics I've tried to show here to show that there could be an infralateral defect, we call it, because of the RCA and circ lesion or blockage. Anteroseptal defect, as seen with an LAD lesion or blockage. And these are the various views: a short axis view, a vertical view, and a horizontal view. Okay, so just quickly going over the stress test, the protocol. Basically, it requires an injection of a radioisotope called technetium-99, which is injected at the peak of the stress. When the person says, I cannot walk any further, allow yourself about 60 seconds to quickly inject, because the IV is already in place, and at that point the injection is done. And there is a standard dose for that, which we're not going to get into right now. But the fact is that as soon as after the injection is complete, patient is monitored for a couple of minutes and the EKGs are recorded, and then the patient is moved under the camera for pictures. Now, once the pictures are acquired, then the patient gets to sit for 2.5 hours, can only sip water, maybe have a little very, very light snack, because obviously the patient has been fasting since overnight before the stress test. And then a re-injection is performed about 2.5 hours later for resting images, for the purpose of resting images. Now, the resting images are performed without obviously any stress involved. The patient goes under the camera directly and the images are recorded. So you look at the stress images and the resting images together and then say whether there's a reversible defect versus an irreversible defect. Normally, the full interpretation is done with a team of cardiologists and a radiologist together sitting and looking at, the cardiologist will look at this part of the stress test, the radiologist can look at this part of the stress test. But if you have a specialist called a nuclear cardiologist, he can do or she can do either of the or the complete interpretation of the entire nuclear stress test. Another advantage, just if you do a plain treadmill stress test, the sensitivity and specificity ranges roughly about 65 to 70% the tops. But when you're doing the nuclear stress test, you're hedging towards 85, 90%. Now that is closest to short of doing a cardiac catheterization. The only problem is there's some radiation involved, so just make sure all the patients are screened well for pregnancy, because pregnancy is a big no-no. You cannot have this patient, have a pregnant person even come near the nuclear lab. All right, thank you so much.